Thyroid cancers, papillary um, thyroid cancer takes up radioactive iodine. Follicular and Hürthle cell take up radioactive iodine. Medullary is associated with multiple endocrine neoplasia, does not take up radioiodine, and anaplastic does not take up radioactive iodine. Functioning thyroid nodules are rarely malignant. Workup for thyroid cancer, asymptomatic palpable nodules, usually how this presents. Ask about hoarseness, dysphagia, odynophagia. Obtain T3, T4, TSH, and thyroglobulin antibodies. Get a thyroid ultrasound. Get a neck ultrasound or MRI for adenopathy. Get an FNA. No contrast with CT. If the FNA is positive for medullary thyroid cancer, order serum calcitonin, CEA, serum calcium, urine catecholamines to screen for pheochromocytoma, and a PTH for parathyroid, multiple endocrine neoplasia. If FNA is positive for anaplastic, do full body staging. T staging, T1 is less than or equal to 2 centimeters limited to the thyroid. T2 is 2.1 to 4 centimeters limited to the thyroid. T3 is greater than 4 centimeters with or minimal extrathyroidal extension. T4A is invasion of the larynx, trachea, esophagus, or recurrent laryngeal nerve. T4B is prevertebral fascial involvement, encasement of the carotid or mediastinal vessels. Note all anaplastic thyroid cancers are T4. End stage, N1A is level 6, pretracheal, paratracheal, and Delphian nodes. N1B is cervical, retropharyngeal, or superior mediastinal nodes, and M1 is distant Mets. Stage 1, age less than 45, so younger is better. M0, or age greater than or equal to 45 and limited to T1. Stage 2 is age less than 45, M1, or age greater than or equal to 45 and T2. Stage 3 is either a T3 tumor or N1A. Stage 4A is a T4A tumor or N1B, meaning cervical retropharyngeal or superior mediastinal nodes. And stage 4C is M1, distant Mets. Management should be surgery followed by radioactive iodine ablation for papillary and follicular. For T2 positive or select T1 tumors, also do TSH suppression with Synthroid. Surgery is thyroidectomy and lymph node dissection of levels 2 through 4 and 6 if clinically node positive or pathologically node positive. Differentiated thyroid cancers, papillary, follicular, Hürthle. The role of radiation is controversial. There's no high-quality studies. NCCN says consider if there's gross, unresectable residual disease in the patient for whom there is poor iodine-131 uptake. American Thyroid Association says there's no role for routine adjuvant external beam radiation. Consider if the patient is greater than age 60 with extrathyroidal extension. Consider adjuvant radiation in patients undergoing multiple neck reoperations for local regionally recurrent disease. Medullary thyroid carcinoma. NCCN, adjuvant radiation is rarely recommended. Possible slight improvement in disease-free survival for those with extrathyroidal extension or extensive nodal involvement. You can consider for grossly incomplete resection when additional attempts at resection aren't possible. ATA, consider external beam radiation treatment for extensive nodal disease, residual disease, or extrathyroidal extension. Anaplastic carcinoma, if felt, can get an R0 or R1 resection, surgery, then post-op radiation, and consider adding chemo with weekly paclitaxel. Otherwise, definitive radiation, consider adding chemo, weekly paclitaxel as per open RTOG trial. 66 and 33 fractions to the gross disease. GTV plus 5 millimeters would be your CTV. 59.4 and 33 fractions to subclinical disease, which is GTV plus 1 centimeter plus bilateral level 2 through 4. And level 6, plus upper mediastinal nodes to the level of the carina. Technique and planning, radioactive iodine, 30 millicurie for low-risk disease, meaning T1 to T2 N0, 100 millicurie for high-risk disease, T3 plus or N positive, 200 millicurie for metastatic. It's contraindicated during pregnancy or nursing. Maximum lifetime radioactive iodine ablation dose is 800 to 1,000 millicurie. Volumes, otherwise thyroid plus bilateral neck, levels 2 through 6 plus upper mediastinum, superior mediastinum to the carina. Add level 5 if it's node positive. Cover the tracheoesophageal groove. Nancy Lee book brings the contour behind the esophagus to do this. Planning IMRT, post-op dose painting. Dose 30 fractions, 60 and 54 in 2 gray and 1.8 gray fractions. For ECE or positive margins, 66 gray and 2 gray per fraction. CTV 66, positive margins ECE. CTV 60 is high-risk CTV, meaning the tumor bed, the first echelon nodes 2 through 6, and upper mediastinal. CTV 54, low-risk CTV, contralateral nodes 1B if involved. Gross disease to 70, 63, 56. 10-year overall survival is 90% for papillary, 85% for follicular, 75% for Hürthle cell, 70% for medullary, and anaplastic. The median survival is 6 months. Radioactive iodine ablation, iodine-131, half-life is 8 days. Acute side effects include sialadenitis, cystitis, gastritis. Chronic include leukemia, pulmonary fibrosis, and oligospermia. Follow-up TSH, thyroglobulin antibodies every 6 to 12 months. Neck ultrasound is clinically indicated. For medullary thyroid cancer, follow calcitonin and CEA imaging if labs are positive.